in Marathon provinces. Drive all the way across.
Before we get started, I do want to remind everybody that this will be our last meeting until probably next October.
Yep.
If you think you're going to come in next Friday and get a meal, that's...
Actually, I think we're probably going to
So this
come
will
back
be our
down
last
to
meeting.
Maine.
Appreciate everybody's support, what we were doing, and I hope you enjoyed the speakers. Before we introduce the speakers today, I wanted to let you know that Marla Williamson in the back, this will be her last meeting. She's transferring to the administrative office. I wanted to thank her very much for all the work she's done this year. Our speaker today, Dr. Chauhan, is one of our new physicians who arrived here in 2012. He went to the medical school at the Government Medical College and Hospital in India. He did a residency in internal medicine and a fellowship in nephrology at the Drexel University College of Medicine and Hahnemann University Hospital. And I'm sure you remember that several of our speakers have been there from there before, and we have several staff members who are also trained in Drexel. He's been here only since 2012. He's boarded in the American Board of Internal Medicine, and he will be our last speaker. Thank you,
Dr. Tinkerman, for the generous introduction. I just hope we got the right guy. But anyway, I've been here for about 10 months now. Moved from Philly. I'm boarded in nephrology and internal medicine. Hypertension is an area of special interest, as is the newer therapies to retard the progression of development of CKD. So what I'm going to talk about today kind of converges on both those two topics, and we're going to see why these newer modalities that are coming up for treatment of hypertension, how that might influence it, how those two things could affect not just outcomes in kidney disease, but everything, heart failure, hypertension, sleep apnea, diabetes. So we're going to talk about a little bit about those. So let's get started. Full disclaimer, this talk deals basically with two kinds of devices to treat hypertension. I don't have any vested interest in either of those. I didn't buy stock in those. My family members aren't employees of any of those corporations. But this is the overview of my talk. So, since I'm going to talk about two different device-based therapies to treatment of hypertension, the structure would basically be, the first step I'm going to talk about the physiological background. And this basically concerns sympathetic nervous system, what's its role in the development and treatment, in development of hypertension, and not just hypertension, but everything that, comes down the line, like insulin resistance, diabetes, sleep apnea, and everything else. And then, can we artificially hope to modulate that physiology and treat those disease entities like hypertension or heart failure using these devices rather than medications alone like we've been doing traditionally? I'm going to talk about the devices and how they work, and then finally the last part of each section will deal with what's the evidence so far to support the use or not support the use of these devices. Both these devices for the time being are investigational in the US, but they have already been approved in Europe and Canada, where they are being used for treatment. Just a quick definition of resistant hypertension, because this is what the indication for use of this device is. You're not going to use these approaches for run-of-the-mill hypertension that can be controlled with one medication, but basically resistant hypertension, and the definition is where you need at least 3 medications to control the blood pressure and still not control. One of those 3 medications must be a diuretic, or if you need 4 medications, even if you achieve blood pressure control of targets less than 130 or 80 or whatever, it still qualifies as resistant hypertension. These are the conventional steps you would probably use so far to treat resistant hypertension. I'm sure you already know that, so I'm going to skip through that. But a big part is compliance being an issue, and I'll tell you why this becomes a big problem and how these two approaches can take care of at least the compliance part. And then let's talk a little bit about regulation of blood pressure. As I mentioned, the first part of the talk is going to be a little bit of physiology. We already know this is physiology 101. Cardiac output and peripheral resistance are the two big drivers of peripheral blood pressure. Arterial resistance is a function of the diameter of blood vessels and directly proportional to the fourth power of the radius. Cardiac output is obviously dependent on electrical and mechanical forces that are generated by the heart, and both of these are dependent, modulated by the sympathetic nervous system, which makes the sympathetic nervous system a very attractive target for treating hypertension and anything that would have a there within the sympathetic nervous system. We probably already know this, but the idea is that the sympathetic nervous system forms the pathway between nervous system and the kidneys, and they talk to each other besides the heart and control the blood pressure. This is, I promised Dr. Lieberman I'm not going to put any complicated diagram on sympathetic nervous system pathways. So this is just a pictorial representation of the sympathetic and the parasympathetic nervous systems on either side of the brain here. And what I need to focus on is that, how the sympathetic outflow from the thoracolumbar section of the spine and the parasympathetic ganglia accelerates the heart and directly influences epinephrine and norepinephrine production by the adrenal glands and the kidneys. And what we're trying to do is modulate this pathway essentially. Just this interesting, what I thought was an interesting historical segue here. The name of this gentleman is Claude Galen. He lived in modern day Turkey, and that was about the year 380. Usually considered one of the greatest physicians, researchers, scientists, and philosophers of his time. His textbooks were standard medical reading for most medical students from the year 300 to almost the 1600s. So I don't think a lot of physicians today would have their legacy endure for more than 1,000 years, but his did. He wrote the first treatise on sympathetic nervous system and autonomic nervous system. He was the one who first described the flow of blood before William Harvey explained it again in 1638. But he was the one who came up with these terms, sympathetic, what it means, and what it probably does. So essentially, what I want everyone to focus on now is, forget about the global sympathetic nervous system. Let's just focus on that small section. As we all know, the kidneys, they're supplied by the renal arteries. Circumferentially along the wall, in the renal artery, you have this arcade of nerves, and those are mixed nerves, so they will have both sympathetic and parasympathetic outflow and inflows. And that's how not only the sympathetic nervous system communicates with the kidney, but the kidney also sends sympathetic and signals back in the form of sympathetic afferents or renal outflow back to the nervous system. And what they've seen in many basic science studies so far is that the sympathetic nervous system tends to be chronically hyperstimulated, not only in hypertension, but also in other states like congestive heart failure, diabetes as well. And the kidneys do seem to play a big role in that regulation, and that's why I'm harping on and on about that part. We all know that short-term regulation of blood pressure also depends on the sympathetic nervous system. If we all stand up from a sitting position, it's not like the renin-angiotensin system kicks in like that. The initial reason why we don't become orthostatic is really the contractility of the blood vessels that is regulated by the sympathetic nervous system. Again, this is the pictorial diagram of what I just explained. Anytime the kidney sends ischemia, they do send signals back to the sympathetic nervous system via the renal afferent nerve, also known as renal outflow. And what the sympathetic nervous system in turn does is that it revs up the sympathetic activity, and the kidneys, the renin-angiotensin system kicks in. sodium retention develops, hypertension develops, hypovolemia, and all the downstream effects that we are very well aware of that happen whenever you have the renin-angiotensin system. CHF is a big part. The afferent nerves also are the reason why the kidneys communicate with each other. This afferent signaling to the sympathetic nervous system not only increases the sympathetic outflow back to the kidneys, but also to the other organs. So you expect effects on the heart, and we know that cardiac hypertrophy is a major development in hypertension, ischemic heart failure, as well as the blood vessels, and we know that the blood vessels tend to become closed. So suffice it to say that over here, at least, an overregulated sympathetic nervous system seems to be the bad guy. Sympathectomy, which is what we are essentially doing here, we are cutting the sympathetic nerves in the walls of the renal arteries. It's not a new concept. Before, bloodletting was the standard medical care for hypertension, and phlebotomist was also known as a hypertension specialist. Sympathectomy was really explored in big detail, major detail. This is a paper from Mayo, 1952, where they describe sympathectomy for hypertension. They didn't do it in as delicate a way that we are doing it now, or trying to do it now. This was more brutal. You either took the kidneys out or you did a splenectomy. And obviously the results, yeah, you did fix the hypertension, but the patient was always orthostatic. There were other side effects like impotence and headaches and everything that comes with loss of the sympathetic drive. So it kind of fell out of favor. This is from the British Medical Journal, 1955, again discussing the medical advantages of treating hypertension, wasn't doing it this way. And this is a paper from 1972. So yeah, it was big in the 40s, 50s maybe, then kind of fell out of favor once we found newer and better medications to treat hypertension. Guanidine hydralazine came along, and then we got on to the better drugs. So no one kind of pursued this. And then over the time recently, when people realized that resistant hypertension is a big major health issue, and a lot of times you're not able to correct blood pressures even using 5 or 6 medications. And not only that, there are lifestyle barriers, there are compliance barriers, so people started to explore this again, and there were more human and animal studies done to see if this could be done a little more feasibly now that we had the luxury of neurotechnology to target specifically the sympathetic nervous system without taking the whole kidney out. So this was in circulation in 2002, I believe. What they did was a pretty interesting study. What they did was patients who already were on dialysis, they took their kidneys out, and these were patients who didn't have any residual renal function. So they did, and this was obviously investigational too, and they demonstrated that the muscle sympathetic nerve activity comes down, the calf vascular resistance goes down, renal arterial pressures go down. And this was a proof of concept that you could still do it and treat resistant hypertension in patients who were, weren't responding to the measures. So that's how we came to device-based therapeutic approaches. This was just a background so far. I specified investigational because in the U.S., at least for the time being, they're both being studied. They have approval in other countries, but not here. And the idea is to cut off the nerves, electrical impulses between the kidneys and the sympathetic nervous system. But for the second part of the talk, I'm going to talk about the Baroreceptor Activation Therapy, and again, that also majorly involves stunning the sympathetic nervous system or fooling it a little bit. So this is a representation of what I explained the technology works. Marla, do we have internet access here? Can I play a video?
Pardon me?
Can I play a video? Do we have internet access on this computer?
I'm not sure.
If we don't, I'll still explain it, but no. Okay, well that's didn't make it past the firewall. But anyway, so essentially this is what we do. we catheterize the femoral artery. We go up here through the aorta into the distal renal artery, and what we do is that we zap that part, the wall, wall of the renal artery with radio frequency waves, and then this catheter, which lies inside the renal artery, and this is a representation, that arcade of sympathetic nerves that I was talking about. You zap it a little bit, then you withdraw the catheter circumferentially, so it's like it comes back in a spiral form backwards, and you do 4 or 5 of these in each renal artery. The whole session lasts about 40 minutes, and usually, so that it's a percutaneous procedure. It's nowhere close to the barbaric procedures that were done in the 1920s, 30s. But again, this is how the technology works. The video, unfortunately, I couldn't play it, also kind of explains the same thing that I just talked about right now. I think I'll talk about this later. So the reasons why this could work is because not only you reduce the sympathetic supply to and from the kidneys, you're also inducing, the moment you cut off the sympathetic supply to the kidneys lose their sodium avidity because of loss of renin-angiotensin system, and they begin to pee out more sodium. So obviously that helps with the blood pressure control and the CHF control. So we talked about the first part, physiology. Second part was how the device works, and the third part is the evidence. So this is an overview of how the evidence for sympathetic denervation of the renal arteries has evolved so far. The first study was called the Simplicity Hypertension Study. This was done in centers across the European Union and Australia. Series of pilot studies which were basically proof of concept that this can work and can work safely. Simplicity Hypertension 2 was the first randomized trial, which actually compared it with medical management as well, and demonstrated the safety of the procedure. And where we are here right now, it's called Simplicity Hypertension 3. This study is still recruiting in the US. Tampa General is the closest recruiting place and you can enroll a patient if you have one. And then they are still